Dr. Deepak Patel. Next, I would like to request Dr. Devika Bhattacharya Mandlik to be ready.
Good morning, everyone. I am here presenting a case on bilateral optic disc swelling with persistent visual loss in anemia. There is no any financial interest. It's never easy to diagnose the cause of painless bilateral optic disc swelling because of its extensive causes. Among these, the most likely etiological categories are increased intracranial pressure, infectious inflammatory, demyelinating, toxic metabolic, and malignant hypertension. Here in this case report, considering the clinical characteristics, all the differential diagnosis ruled out, sticking the diagnosis to intracranial hypertension and bilateral non-arteritic anterior ischemic optic neuropathy. After proper workup, it was found out that here anemia is responsible for bilateral optic disc swelling. The case report is a 56-year-old man with medical history of recurrent gastric ulcer was admitted and had complaint of acute painless vision loss in the left and right eye for 5 and 3 days respectively. Prior, he had experienced a solitary episode of melena on the same day. Physical examination showed pale skin, normal hydration and normal heart tones. Blood pressure was 86/60 and heart rate was 94 beats per minute. ECG was normal. On ocular examination, the vision was 6/18 in the right eye and low light perception in left eye. On pinhole and BCVA, the vision didn't improve. Extraocular movements were full and free and painless in all gauges. Head posture were central. Lid and adnexa were within normal limits. On anterior segment examination, conjunctiva and corneal were normal. Anterior chamber shows normal depth in both eyes. Iris had normal pattern. In pupil examination, the RAPT was found in left eye. The lens was clear and IOP with aflumination tonometer were within normal limits. On fundus examination, media were clear. Optic disc shows hyperemic swollen discs in both eyes. Cup disc ratio and neoretinal rim was not appreciated in both eyes. Macula were normal and foveal reflexes were present. On general fundus, tortuous swollen retinal veins and narrow arteries were found in right eye. Dilated and tortuous vein with flame-shaped hemorrhages are found in left eye. Automated perimetry revealed a superior altitudinal defect in the right eye and there were no any signs of giant cell arteritis. Lab results showed severe anemia with hemoglobin level of 4.8 and low mean corpuscular volume, an iron level of 11 and a ferritin level of 9 microgram per liter. Both CRP and ESR were within normal range. GGT was elevated. Vitamin B12 deficiency was ruled out. Folate was also within normal range. CT of brain showed no space occupying lesions, significant stenosis or recent infarction. CT of abdomen showed no any abnormality. Both gastroscopy and colonoscopy were normal. Severe anemia resulting from a gastric ulcer causing bilateral optic disc swelling with possible hypoperfusion and NaION was retained as working diagnosis. Following blood transfusion, hemoglobin increased to 8.1 milligram per deciliter. Optic disc swelling waned, vision in the right eye improved but didn't recover in the left eye. The picture 1 showed the fundus picture of the right eye showing clear media with hyperemic swollen disc, tortuous swollen retinal vein and narrow arteries. The left eye fundus picture shows optic disc swelling, dilated and tortuous veins along with flame-shaped hemorrhages. The automated perimetry of the right eye shows superior altitudinal defect. On discussion, the present case shares both features of NaION and anemic retinopathy. Both papilledema due to intracranial hypertension and NaION may result from anemia. Anemia increases erythropoietin levels which trigger thrombocytopoiesis. As a result, thrombocytosis increases viscosity and clot formation. Macrocytic anemia due to iron deficiency may also increase viscosity with reduced cell deformability due to inhibition of thrombopoiesis by iron. Hyperviscosity may subsequently increases venous pressure, which then decreases CSF resorption and increases intracranial pressure. Treatment of anemia in itself may improve optic disc swelling and vision, suggesting a direct association between optic disc swelling and anemia. In the case presented, correction of anemia improved vision in the right eye drastically in the short term. Since such improvement is less likely to occur in NaION, anemia seems to play a pivotal role in the present case. The pathogenesis of NaION may encompass hypoperfusion of the optic nerve head and more rarely an embolic lesion. Bilateral NaION is most often reported after hypotension and or anemia following dialysis and surgery. Limitation in the present case that since the patient was hemodynamically unstable, a lumbar tap and magnetic resonance venography were impossible to perform in order to objectify possible intracranial hypertension and exclude cerebral venous sinus thrombosis respectively. Both would have been helpful. In conclusion, both papilledema and NaION may be associated with anemia and always need to be included in differential diagnosis of patient presenting with bilateral optic disc swelling and painless loss of vision. Routine workup should include a CBC, serum iron, and vitamin B12. If anemia is present, prompt correction is crucial as it may limit optic nerve damage and enhance the visual outcome. These are my references. Thank you.
You have mentioned the patient has no, visual status is no PL
Yes,
in
ma'am.
left eye.
Yes, ma'am.
What is the role of pinhole testing after no PL vision?
Sorry, ma'am?
You have mentioned that the patient's vision in left eye
Is no
no,
PL.
no PL, and after that is you tried to improve the vision with pinhole. I mean, what is the role of pinhole in case of no PL vision?
No, ma'am. The patient already had symptoms in the fellow eye too. That's why we are checking the pinhole.
Yeah, but it should be, after pinhole, you have mentioned is a no PL, then what is the role of pinhole?
Ma'am, there is no role in if patient has PL negative.
So your working diagnosis was NAION, but
Yes.
no PL, like
So it is not uncommon that the patient started complaining if when both eyes are involved. In my cases, it is possible that the patient had sequential optic nerve involvement initially, which is undetected, but he start complaining when second eye was involved.
I feel needs a little bit of further investigations regarding imaging and all.
So has this case report been published already?
No, ma'am.
Any similar studies? Any similar reports?
No, sir, I didn't found any similar cases in India.
There are many. There are a few. I think you have to search.
You can check when you go.
Okay, thank you.